Or you guys want to lead the conversation?
Well, we'll lead it, but you'll do most of the talking. All right, we're here. We're on the road. We're headed to Cleveland. I'm here with Dr. P, myself, and then we got
Dr.
world
Mack.
famous Dr. Tariq here. How are you,
Tariq?
Doing great. How are you guys doing?
So, do you like to be known by Tariq or Dr.? How do you say your last name?
Hacky?
Hacky?
Dr.
That's right.
Hacky.
That's right.
So Dr. Hacky is awesome. I mean, he is doing a very prestigious fellowship right now, and then he's going to be going to another city. We'll kind of let him talk about, who he is, where he did his schooling, and where he is now, and what the future holds for him. Dr. Hacky, welcome to the Drive for Men's Health.
Thank you. Yeah, thanks for inviting me. This is a great opportunity. So I'm finishing up my fellowship at Baylor here, and I trained initially in my residency at University of South Florida in Tampa, and now I'm finishing up at Baylor. So I'm heading to Atlanta, and I'll be working with advanced urology out in the suburbs, northeast suburb. Okay, are you guys coming in there?
Yeah, I can hear you. Can you hear me?
Oh, no, I think I just lost you guys a second ago.
Oh. No, but we can hear you. So are you excited to move to Atlanta?
I'm excited about it. I'm stoked. It's good to be moving on.
It's good to finally be done and get a real paycheck. I will tell you, it is awesome, and then to be your own boss. So tell us, you want to talk about Peyronie's disease now. Peyronie's disease is something that most people don't really like to talk about or don't even know it's a real disease until they either become sexually or things start hurting. So our audience is very general, and they may not know a lot of the urology stuff. So if you don't mind kind of telling us what exactly Peyronie's disease is, that would be awesome.
Yeah, so Peyronie's disease is formation of scar tissue in the erectile tissue of the penis. And this has many theories as to why this occurs, but it causes penile pain and deformity. And what a lot of guys don't know is, this is a problem that's, about 5 to 8% of the male population, but, some men are told that they're okay with watchful waiting. Which is not an okay. And recent studies have shown that 30% of men fail to progress if they have no treatment given to them. So this is definitely a disease that's out there with a lot of stigma, and a lot of men just choose to ignore it and live with it.
Well, so the thing is I get a lot of patients that say, "Oh, I have an angulation," but they don't really have a curvature. So is it normal for men, not talking Peyronie's, to have a bend to the right or the left?
Yeah, they can have a congenital curve, up, right, left, and even down. But I mean, they can just, as long as it's not affecting the intercourse, and it's something that's always been there and it's not changing, I would advise not doing anything with it. Just kind of monitoring it and seeing if it's causing them a lot of distress, and it's something we can bring up and talk about how to manage that.
So when you say patients, so let's say someone has this abnormal curvature, what will you or someone that specializes in this do for them in the office, when they first go see them?
So
do they just crack these things, or put you on drugs or something? What is it exactly?
So, so first of all, you're going to do a good history and physical examination, but many patients will actually come in with photos of the curve, and they can say, "Hey, look, doc, this is what's going on right now," and they'll show you several pictures of the curvature. And then, on top of that, we try to get some questionnaires to give us an idea, of how their erectile function is and how they're overall doing. And then we can do something called a penile Doppler, an ultrasound, where you cause an artificial erection, and it gives you an idea in the office of how their curve is and what degree of bend and deformity that they have. It gives us a lot of information. There are a couple of questionnaires that are out there, the PDQ and the IIEF, which are some of the questionnaires that some people use.
So what I don't get is, why do you need an ultrasound then? I mean, if you just want to do an artificial erection, how does the ultrasound help the whole process?
So the ultrasound can give you an idea of one, the actual curve, and you can get like a little machine out called a goniometer and get the angulation of the curve. But also tells you, where the plaque is or the scar tissue that the patient has, and also tells you information of how thick it is, and it gives you a general feel of how bad the Peyronie's disease is and how the patient's coping with it, as far as can they penetrate, what angle of degree they have, and how strong their erections are, which is also important in how you're going to treat them.
So when you say treatment, now I remember from residency, it was like 1/3, 1/3, 1/3. 1/3 get better, 1/3 stay the same, 1/3 get worse.
Yeah.
Is statistics, because you see a lot more of this than I do. And when I get a Peyronie's patient, I send them away. So
you can send them up if you want. Send them north to Atlanta. We don't mind. So that is true. The general mantra: the 1/3 get better, 1/3 stay the same, and 1/3 eventually get worse. But there are two phases to Peyronie's disease. There's an active phase, which lasts 6 to 18 months, where the patients have active inflammation and they complain of penile pain and they have progressing deformity. And then there's the second phase, or the stable, painless plaque phase, where they just kind of live with this deformity. And it's patients that are patients in the active phase. You're not going to do anything other than assessing how they are and starting maybe medical therapies for them. It's the patients that have the continued stable plaque, that we're going to consider for surgical treatment and consider further therapies if they're not improving on the non-surgical therapies.
So what's the latest with vitamin E? Like, is that still like a sham, or does that really work?
So vitamin E is a scavenger of free radicals, and it's associated with decreasing anti-inflammatory effects seen in the penis. However, there's a couple of studies, I think double-blind placebo done in 2007 in Journal of Urology. It showed there was no improvement of vitamin E in the use versus placebo. So, vitamin E is kind of still just more theory rather than actual application. It's the same thing with other medicines like Pataba. Colchicine has been used, but in combination with vitamin E. I think there was a study in BJUI which showed that there was some decrease in pain and early plaque formation when it was administered early.
So it's not. I mean, what is your usual thing? Like when patients come in, what's the first thing that you do for them?
So as far as medical therapy go, we usually use pentoxifylline, which is a non-specific phosphodiesterase inhibitor. And there have been several studies that look at that decreases the calcium content inside the penis in different rats models. I think Tom Liu did a study in 2011. There's a couple other journal articles showing that pentoxifylline can, when given early, can reduce the effects of the fibrosis in the penis. So usually we give patients pentoxifylline in combination with L-arginine, which has been shown to decrease the overall inflammatory process, because the theory is that this is runaway inflammation that's causing the Peyronie's disease.
Oh, okay. So would you say patients that have like inflammatory disorders like scleroderma and stuff are more prone to Peyronie's? Or like
there's a genetic component, but I'm not sure if there's a component there. The elastic tissue of the penis has no blood supply to it. So when you have like these micro stress fractures that cause Peyronie's disease or the scar tissue formation, you have issues clearing out these inflammatory agents. So that's why we give patients anti-inflammatory agents initially.
Okay. Now, what are some of the surgical options? If a patient fails the stuff, I know there's injections that we can give.
Yeah.
I used to give calcium blocker injections, which I think no one does. But I think there's some newer things that, if you don't mind kind of sharing with us.
Yeah, so right now, there's the old mantra of IFN and other injectables like steroids, and those have kind of fallen by the wayside as Xiaflex or the collagenase has kind of come into favor. And that's essentially 2 injections with modeling episodes after that. And this is an inhibitor of collagen buildup, and you inject the plaque, and then you just essentially are recracking the plaque again. And this is noted 30% improvement in the early studies. And this is just recently FDA approved, finishing clinical trials, I think last year, 2 years ago. So we're using a lot more of the XIAFLEX initially. Patients that come in, initially are in usually the active phase, and we have to wait for them to kind of get into that stable plaque phase, and we can offer them the XIAFLEX
so
injection.
you would during the active phase, so you would probably wait.
Yeah.
Oh, wow.
We put them on like vacuum erection therapy along with L-arginine and pentoxifylline. There's another study that's shown PDE5 therapy, or like Cialis, daily Cialis, is also beneficial. That was also noted to decrease scar formation when compared to placebo trials. But usually that's where we start off, and then we'll move to XIAFLEX therapy. We'll discuss the option, and a lot of insurance companies are taking, so it's really a great option for patients these days.
So that's pretty neat, man. So surgery, like I know some of the surgeries are pretty intense. Now, what I always tell my patients is for Peyronie's is I can probably do some of these surgeries, but you want to go somewhere where they do this all the time, or someone that's been fellowship trained in this, because I always tell them is, if I'm going to do a surgery, there's a potential of me scarring things, so I may cause this to even get worse, or you may even go through pain. And I've seen some patients that come to me for second opinions that have had surgeries done elsewhere, and I'm like, wow, like this it looks kind of rough, because they'll come in like totally bent, like 180 degrees. So I think you have, like, I would say, one shot at this, correct? Like, you guys, where you are right now as a center of excellence, you guys probably see a lot of patients for second opinions as well, correct?
Yeah, we see a fair amount. Usually, if they've passed through the other medicines, a lot of people are still using the topical therapies and the injectable IFN and the older injectable therapies. We're having good results with XIAFLEX, but some patients don't want to have the needle injection. It's quite painful, and they have to have several cycles. So they're having 2 injections, and then they're having a molding event, and they can't have intercourse for a couple of weeks after the injection. But then we talked about surgical therapies, and you kind of have to think of it: are you going to fix the bad side, or are you going to correct the bad side, or are you going to make the good side worse? So what you can do is you can shorten the good side, straightening the penis that way, or you can kind of fix the bad side by removing that piece of elastic tissue in the penis and putting what's called a patch over it. But these are very technically challenging surgeries. So I would definitely,
since you're an expert at it.
Yeah, definitely go to somebody that's very comfortable doing that surgery, because there's a lot of nerves and blood vessels in that area. They have to make sure that you're able to move appropriately for the surgery. And then there are some patients that have poor erectile function, and they have bad, Peyronie's disease. And then we discuss with them the use of a penile implant, and that comes with its own pitfalls. But overall, we're able to correct those patients and make them within 10 to 15 degrees, of a curve of what they formerly had, and we're able to resolve their erectile dysfunction. So we're able to do a 2-for-1 deal by putting in the penile implant with those patients. That's why the artificial erection and the Doppler is very useful to kind of give us an idea of their overall erectile function. There's the theory that erectile dysfunction causes Peyronie's disease, because most men, it comes because of penetration or buckling, and they get these microfractures, and that's what causes the scar tissue buildup, But I always try to counsel patients to be very careful, and we give them all the options, starting off with like the conservative therapy, then going on to traction therapy or the vacuum erection device, and then moving on to XIAFLEX or the injection therapy, and then surgical therapy finally if they've exhausted the other ones or they don't want to undergo the shots.
So most men, I mean, the whole goal of the Drive for Men's Health is trying to get guys in to see the physician earlier. So when it comes to Peyronie's, it seems like if you start feeling a bend or it hurting, you should go see it. You should try to get treatment during the active phase rather than when it stabilizes, correct? Or is this one case where you want to kind of see what happens?
No, well, I mean, there's a 30% chance from the historically that you're going to get better, but going in, getting treatment earlier is better. You can decrease the amount of inflammatory tissue that happens. Studies have shown that you can decrease the amount of plaque buildup, and you can improve the overall, outcome of the patient by giving them early therapy. So I tell men, if you're having, curvature with an erection that's abnormal, it's painful, you're having, those symptoms, of curve and being inability to penetrate, get treatment early, because, there's things we can do to stabilize this scar tissue, and treat it, and there's a big stigma for this. And I think that, there are other therapies beyond that, that we can do to intervene later on, once everything has kind of stabilized and quieted down. But a lot of guys, we can fix them with just medical therapy and traction therapy before they even get into, the whole so like shots therapy or like the surgical therapy.
Fantastic, Aki. Well, thank you so much for joining us. Any tidbits on Men's Health? Because you're about to go to Obesity Central and some, in the States. Actually, I guess where you are right now, there's an epidemic. I guess there's an epidemic all national.
I think it's all in the U.S.
So we want to make sure that we get guys to get in earlier, not just for Peyronie's, but all urologic diseases, actually all medical diseases. And we appreciate you taking the time out of your busy schedule to meet with us today and talk about Peyronie's. And any last words or insights that you'd like to share with us?
Yeah, I can't stress how important it is for men to have a healthy diet and exercise. It's extremely important for cardiovascular, and also for the overall men's health in general and sexual health as well. So, if I can push any of those points home, I definitely would, because it's a very important thing you guys are doing, and I don't think enough guys pay attention to their health, and we wait for things to be too late. In cases like Peyronie's, there are treatments out there. There's no longer the stigma around this. We're trying to become more vocal about men's health, and I really think what you guys are doing is really important.
Well, we appreciate you being a local driver, and you're going to be our local driver now in Atlanta, where you are today. So thank you so much. And one last thing. There was this new toy where you were using. It's like a 3D helmet or something. What is that stuff? Are you going to be doing that in Atlanta?
Yeah, so it's a 3D headset, and basically whenever you're doing microsurgery, only the surgeon can operate in 3D. So what we've done is we basically, Sony's created a 3D headset, so we're able to attach that to the microscope and operate without putting your head to the microscope, and essentially just wearing what you need to operate, which is really kind of handy. You don't have to look into the microscope, adjust the levels. It's kind of cool.
That's awesome, man. Well, we look forward to keeping in touch with you, and definitely follow us at dropformenshealth.com. We left New York. We're on our way to Cleveland, so we got a long journey ahead of us, and we appreciate your support, Dr. Aki, and you are awesome. And best of luck in your new practice. I guess you're going to be joining very soon, right?
Yeah, I'll be starting in August. I'm really excited, but it's been great just talking to you guys, and I think this is a really important thing that you guys are doing. Thank you for including me on this. It's great.
Thank you, sir. Thank you. And
Thanks
we'll
so
see
much,
you later.
Guys. Yeah, take care.
Thanks, bud.
Thank you, Dr. P. Thank you.
Bye.
All right, take care.
Bye. He's
Bye.
driving, so he can't talk. Bye, Tara.
Yeah, no worries.
I think you have to click off, or I don't know, Tara.
I'll click leave call.
Yeah, leave call. Yeah. All right, team. Well, next up, Will Bay.
What time are we scheduled to get to that?
Hello, sir. How are you? Yeah, of course. You doing all right? Yeah. Absolutely, man. Thank you for your support, man. We really do appreciate it. So No, no, no. It's better this way, man. It's better this way, man. And then when you have your own TV show, please invite us on. All right. Yeah. No, thank you, man. Thanks for believing in us, because there's a lot of people that don't, but I think we're
but I'll hopefully get it working in a minute.
Oh,
Just
no,
give me 1 minute to keep. I just entered an activation code.
no, that's fine. If you can't, we'll just do it definitely. Just call me. This is actually Sijo's number because it's hooked up to the car. But just call us if there's any issue, and we're just waiting. We're on it right now. So cool.
Okay, I'll be right there.
Thanks, Stacy. Thank you.
Okay.
Thank
Bye.
you. Bye. Before you say anything. Hey, Stacy.
Hello.
What's up? How are you doing?
Great. How are you guys?
Good. We are in the tunnel in Baltimore.
It's a bit
Hold on.
dark.
We're gonna come out of the tunnel with you here. We're going through. We're hitting some rush hour traffic, but we are going through and we are outside. But we're doing pretty good, Stacy. We are about 2,200 miles into our journey. We got about 4,000 more to go. We were in New York yesterday, today, and now we're headed to Cleveland.
Fantastic. Well, congratulations on this amazing effort. Very important to raise awareness for men's health.
Yeah, and thank you for joining us today. And we're very excited. Yeah, do you know Sijo? Sijo's my partner.
I won't
How
be
are
saying
you?
to you, somebody has to drive, so thanks.
So, you know what's interesting, Stacey, is we've had a lot of people ask us about prostate cancer, and even though we try to talk about general medicine and blood pressure and diabetes, the conversation always goes back to prostate cancer, because I think when a lot of people think about men's health, they think about prostate cancer. So, our audience, our audience doesn't really know what prostate cancer is. Do you mind just? I know you're a leading expert in active surveillance and prostate cancer research.
Right.
We'll get to that, but what exactly? Why is the prostate so important yet not so important?
Yeah, well, it sure does cause a lot of trouble, doesn't it? So, well, I mean, it is a very common cancer in men, both in the United States and around the world. Some men are at higher risk than others, actually. So if you have a family history of someone with prostate cancer, also African American men have a greater risk. It's just this little organ in the bottom of the pelvis. It's in a bit of a tricky location, unfortunately, kind of high-priced real estate area. We've got, the rectum and the GI tract just behind it, and the bladder just above it, and the nerves controlling erections on the side. So that's why there's a lot of issues related to the treatment of prostate cancer, because it's in this difficult spot amidst all these other important structures for things like your urinary function and sexual function. But, the good news is that it does have a very good prognosis these days, particularly if men get screened early. So early detection really is critical in order to find it at a curable stage, because there's just no symptoms. It only causes symptoms once it's very advanced. And many of the early forms may not even require treatment. So it's important for men to know that a diagnosis is not at all a death sentence. There's so many options if you catch it early. So the key is really to just stay on top of your health.
Now, you mentioned screening guidelines. Like, I myself get confused sometimes. The AUA has one guideline, Europeans have another guideline, and then Americans, the Preventive Task Force says we shouldn't be screening at all. So a lot of my patients come in very confused about what the heck is going on, and then when they do get diagnosed, they're like, well, when should my son get this? So
Right.
In your practice, when do you usually start screening, and then when do you usually recommend, if someone's high risk, just to get themselves screened?
Yeah, so this is a great point and a huge area of controversy. And definitely, the most important thing is shared decision making. So you really need to talk to your doctor about screening, hear about the advantages and disadvantages. Advantages are it's the only way to find prostate cancer early. Disadvantages are it's not a perfect test, and some prostate cancers are not harmful. But you don't necessarily have to act on the results. And that's what I always tell men, that if you bury your head in the sand, the problem doesn't go away. So what's more important is that you gather information, because information is power. So if you know your number, this is a campaign of the AUA, our urology organization, know your number. So once you know your number, your PSA number, you can make your own choices if you want to do anything. You don't have to get a biopsy. If you're diagnosed, you don't have to get treatment. And in some cases, it may be better not to do anything further. But if you just don't know about it, then you're left with no options. Yeah. So my recommendations are that you should have a baseline test in the early 40s.
Okay.
And this is even true for men who don't have any risk factors for prostate cancer, because actually the baseline PSA measurement in the early 40s is a stronger predictor of developing life-threatening prostate cancer than any of the other risk factors. So certainly men who have risk factors are at increased risk of prostate cancer in general and being diagnosed at a younger age. But even if you don't have any risk factors, if that baseline is above 1, you're at a much higher risk of ever developing prostate cancer or ever dying from it. So why not know that information? And if it's not, if it's below 1, then you can feel more reassured that if you don't have any other risk factors and that looks good, then you could at least forget about that for a few more years. Certainly regular testing starting at 50 is pretty standard, as long as you've gone through the conversation with your doctor and decided that this is right for you. Then every 1 to 2 years starting at age 50, until the point that you've got a lot of other health concerns and it's really not a factor anymore.
So I remember one thing is when I was in training, in the beginning of training, everyone got surgery or radiation. And then towards the end of my training, it was like, hold on, you shouldn't be operating on all these people. The term active surveillance started buzzing midway through my training, and now is like it has become almost a standard for a lot of low-grade or very low-grade cases. What exactly is active surveillance? Because a lot of my patients still have a hard time grasping that they can do this when they know this big C word is inside of them.
Right. Well, active surveillance means that you are not going to treat the prostate cancer right now, that it's a low-risk tumor, and it may not cause any harm during your lifetime, so you're just going to watch along, but it's active. You are actually watching and doing testing to make sure that it doesn't get worse, and if it does, then hopefully you're able to then catch it in time to still get treatment with curative intent. Mm-hmm. So this is still active. It's not just, say goodbye to the doctor and forget that it exists. It's, continuing to get the PSA blood test, periodic imaging studies, like maybe an MRI every 1 to 2 years, and getting some repeat biopsies to check if the cancer is growing or becoming more aggressive.
So you would recommend, so I've been in practice now 2 years, so my active surveillance guys have been coming I treat them as if they've had prostate cancer every 3 months, and every 6 months, and hopefully every year. So would you recommend I get MRIs every year or 2 just to kind of see if there's anything that I'm missing or any?
Exactly, and if it can help to decide when they should have another biopsy. So, and it's nice because the MRI technology has really expanded a lot. MRI, many people have had it for their back or some other organ, and it really wasn't used much in prostate cancer until the past few years. But now the technology's improved so much that sometimes you can see tumors, and if you can see it, it's more likely that it's a big, nasty one. So it is something that's helpful to get in men who are on active surveillance, just as an image. It's a picture, and if there is something ugly on there, then that would let you and the patient know that there is a higher risk now, that something has cropped up that wasn't there at the time that we started this strategy, and maybe we need to rethink, should we go forward with some kind of treatment? Should we do another biopsy now and make sure that we put some biopsy needles in that area? where we can actually use the MRI to help target the prostate biopsies. So this is kind of an evolution since it's still, a relatively new technology. We do a lot of MRI work here and have a big experience with it, but it has not gotten to the point where it's completely standard everywhere in the country. So I would just say to, the men who are listening, just to make sure that, if you're going to think about prostate MRI, that you go to a place that has a lot of experience with the technology.
That's very impressive, Stacy. Can you hear me, Stacy?
Yes, I can hear you now.
So I know you like to do a lot of research. What is your what do you like to do research in? Other than social media, I know Stacy is a social media guru. She's my idol when it comes to social media.
Oh, well,
So,
I think you're doing an excellent job and, really just a great advocate for men's health. So very, very impressive. My research is all in prostate cancer. For the past 10 years, I've been doing research on prostate cancer screening and really the importance of screening in terms of outcome. We've shown that men who got screening even had better outcomes when they had surgery from prostate cancer. I've done a lot of research on different testing options. There's so much controversy about the PSA test. It's the blood test that's mainly used for prostate cancer, but now there's all kinds of other markers that are available. One of them that I did some of the work on is called the Prostate Health Index. It's an exciting new test that's actually just like a better version of PSA. It's a blood test just like PSA, similar price, but it's about 3 times more specific for prostate cancer. So I participated in some of the studies that led to FDA approval of this test. So it's good that we're starting to develop some new options in terms of, other ways that men who are concerned about prostate cancer can think about testing. And then most recently, I've been working on active surveillance research. So these are for men already diagnosed with prostate cancer who want to avoid getting treated, especially if they have low-risk disease. What's the best way to monitor their cancer over time and decide when we need treatment? And are we going to lose anything by waiting? And we have a lot of new data suggesting that, really you're unlikely to lose anything by waiting as long as you're followed closely. So with, in the first 10 years after diagnosis with low-risk prostate cancer, the prostate cancer death rate is less than 1%. So that's regardless of whether you have surgery or active surveillance as your initial option. So really, if you have low-risk disease, I think that it is definitely a good consideration and a good option. And that way it's, much less burden for the patients. But, if it's not low risk, if it's a higher grade tumor, a bigger tumor, going ahead with treatment is the way to save a man's life.
So male, that's your hashtag. Save the male.
Yeah, save the male. I mean, truly, because I think what gets lost in this debate about prostate cancer is everyone thinks it's somehow irrelevant or insignificant because there's so much controversy about screening, but it's still the second leading cause of cancer death in men. So if it couldn't be harmful, then, there's no way that it could cause 27,000 deaths a year in this country. So we just have to keep that in mind, and screening is the way to find those people. What we have to do then is just make sure that the other people with the low-grade cancers don't face an undue burden of treatment and side effects as a result of this. So as I see it, screening is critical for us. It's our only way to find the life-threatening tumor at the time, but meanwhile, we've got to do everything possible. Use better screening tests, better, newer, minimally invasive treatment options, better imaging studies, everything we can do in the process to help men through.
Now, really quickly, genetic testing. Now, sometimes patients, I tell them they should active surveillance. They're coming in with their oxygen masks.
Yeah.
They've gotten their biopsies done elsewhere. They come to me for a second opinion. They're like, do my surgery. And then I just get the genetic testing, and sometimes it's really vague. But when they see that paper that says they're low risk, they believe it more than it coming out of my mouth. So do you see a more active role or more important role for these tests
when it comes to helping us with treatment plans?
Well, you know, it's definitely another piece of
And I'm not paid by any of
information.
those companies, so I'm just letting you guys.
Yeah, I mean, it's another piece of information. I think most people come out in the middle where the result doesn't change what you would have suggested otherwise, but there are cases at the extremes where it does change the decision. And, you know, there's not a lot of long-term evidence yet on those. There's definitely evidence showing that those tests change clinical decisions. We don't know whether that was right or wrong. And the tests are pretty expensive at this time. But I think it is exciting that we have other options to try to standardize things, you know, and to just give men more information. And if someone, you know, has a tumor that's kind of borderline, they just can't decide, should I do active surveillance or not? Could we have, you know, missed some higher grade elements on the biopsy, things like that? Definitely sending one of these tests. It's nice that we have more ways to give someone information so they feel like they're making the best educated decision. So I'd say more information is always better, you know. Hashtag save the mail.
Save the mail, woo! Well, Dr. Loeb, thank you so much. And I just want to say I love the background with the shoe, the high heel shoe on your ledge over there. I don't know if you can see it in your office, but can you see it?
That's the tape dispenser.
Oh, is it? Oh,
That's awesome. Well, Stacy, thank you so much for joining us. And you know, we have been having some internet problems, but you are live. But we're gonna get it cut and edited in a few days up there. But thank you so much for being our local driver. You're at NYU, and she has her own radio show on Sirius XM on Men's Health Radio. And thank you so much. I'm your biggest fan, and look forward to you following us and our journey.
Good
and
luck
hopefully
with the drive.
Yes, thank you. And if you're near TV, CBS 2 is talking about men's health and the drive at 5:45. So Dr. Max Gomez
Fantastic.
did a little piece. But we're very blessed to have drivers and partners like you to help us, you know, advocate for men everywhere. So Stacy, thank you so much.
Thank you very much.
Okay, thank
Bye.
you.
Bye.
Safe
We'll see you.
travels.
Bye, Stacy.